Hi, you're listening to It Happened to Me, a rare disease and medical challenges podcast. The mission of our podcast is to support you, our listeners, and to create community as you confront the toughest challenges in life. All of us will experience health hardships. The real question is how we adapt. That's the focus of It Happened to Me, which wants to help you overcome limitations and live a full and satisfying life. Drawing on their own health challenges, co-hosts Kathy Gildenhorn and Beth Glassman interview guests who share stories and research to help you succeed in the face of difficult health obstacles. It happened to me. I'm not alone, and neither are you.
Joining us to discuss neuromuscular neurology is Dr. Robert Bucelli. And I must disclose that I am a huge fan of Dr. Bucelli's, as he is my personal muscular neurologist. For over a decade, Dr. Bucelli has been a practicing neurologist at the Washington University Neuromuscular Clinic. He's a professor of neurology, pathology, and immunology at the Washington University School of Medicine in St. Louis, where he serves as the site principal investigator on several clinical studies relating to ALS. Dr. Bucelli is also co-director of the Washington University Neuromuscular Clinical Laboratory and co-director of the Washington University ALS Center. After graduating summa cum laude from Kansas College in Buffalo, New York, with a degree in biology, Dr. Bucelli went on to receive his medical degree and PhD from the State University of New York at Buffalo as part of the Medical Scientist Training Program.
Dr. Bucelli is an expert in diagnosing and treating neuromuscular disorders, including ALS. His skill in delivering drugs to the fluid surrounding the spinal cord has enabled Dr. Bucelli and the Washington University's leadership team in trials using ASOs to turn off the production of harmful genes that cause ALS. Welcome, Dr. Bucelli.
Thanks very much.
Thank you, Dr. Bucelli. Now, let's start at the beginning. Can you provide our audience with an overview of what neuromuscular neurology entails and who is typically affected by it?
Sure. So the way that I typically will describe neuromuscular neurology to folks that aren't familiar with it is medicine is progressively more and more subspecialized. And within the field of neurology, you could break it down to 10 to 15 different subspecialties within our field.
Wow.
And there's the majority of those specialties are devoted towards disorders of the brain and to some degree the spinal cord. And they have double-digit numbers of specialties devoted towards those portions of the nervous system. And there's only one that's devoted to everything else that's outside the brain and spinal cord, meaning the nerves, the nerve muscle communication point called the neuromuscular junction, as well as the muscle. So neuromuscular neurology deals with all of that, everything other than the brain and the spinal cord. Now, some of the disorders that you're alluding to, like ALS, obviously that kind of spills over and doesn't exactly obey those boundaries. But for the most part, we're dealing with everything outside the brain and spinal cord.
Now, are there typical patient groups that are affected by neuromuscular neurology and its issues?
Yeah, so certainly ALS is primarily followed by neuromuscular specialists, even though it again doesn't exactly fit that rule I applied. But peripheral nervous system disorders, so a very common one, people with polyneuropathy or peripheral neuropathy, folks with muscle diseases, myopathy, myasthenia gravis is a common one of the communication point between the nerve and the muscle. And then those are kind of very common categorical associations with neuromuscular neurology. And then there's a litany of other disorders that fall underneath those, what we call localizations or categories of disease. be it the nerve muscle junction, or the muscle.
And are individuals with rare or genetic disorders and diseases more prone to experiencing neuromuscular neuropathic issues? Or is it a standalone medical challenge that anyone can face?
I would say that, certainly we take care of patients with both hereditary or genetically determined disorders in the classic sense of something being quote unquote genetic. We also, these same categories I was just alluding to can be due to acquired disorders that aren't necessarily genetic. I would say that within the field of neurology, probably the subspecialty within neurology that is the furthest along or has the deepest kind of genetics associated with it is neuromuscular disorders, mainly because of, again, the breadth of what's covered. As I was alluding to, there's so many things that fall within the scope of neuromuscular disease, but also the sheer number of disorders that fall within that. And so I'd say of all of the fields within neurology that end up dealing with clinical genetics, neuromuscular is probably at the top.
I know personally that I have had tremendous difficulty, other than I'm so lucky to have found you as a neuromuscular neurologist, but it has been so hard for me to find anyone else with that specialty. Is it rare that neurologists choose this specialty, or am I looking in the wrong place? What's going on here?
Yeah, it's a fantastic question. I would say that in general, when you look at the US, neurology in general is a field that's very much in demand. There's not enough neurologists spread across this country. I mean, certainly in certain areas with higher populations, the density of neurologists may be a bit higher, but when you look across the entire nation, neurologists are certainly at a shortage. And then when you look within the field of neurology, there is absolutely a paucity of neuromuscular specialists. Even within, the field of neurology, a lot of people shy away from or kind of look away from the peripheral nervous system. I'd often find that there is the need, and a lot of people, while those of us that do it know how great it is and how much we love it, there's a lot. There are a number of centers where there may not be, even at large urban areas, there might not be a single neuromuscular provider in that metropolitan.
My goodness.
Wow.
Doctor, do you treat MS?
No, so MS is one of those disorders that primarily falls. There's actually centers that have like entire groups solely devoted towards multiple sclerosis, or it's kind of similar disorders. But that's a disorder of the brain and spinal cord. So that's another one of those disorders that usually taken care of by neuroimmunologists or MS specialists.
Wow.
I see. Boy, this is a very complicated field, doctor. So can I ask you, so how do you diagnose and treat a patient when they come to you? How do you determine what they have?
One of the beauties of our specialty and what we still do even present day in 2024, despite the fact that technologies are what they are, and you have access at your hand to very powerful things like genome sequencing and all these imaging studies and fancy blood tests, everything like that. One of the beauties of our specialty is that so much of it still rides on the history or talking to the patient and then examining them. We're still very much reliant on that aspect of the evaluation. And the reason why that is still so integral to us is kind of what I was alluding to earlier. There's so many different things that we end up taking care of, and so many different types of disorders that fall within the spectrum of neuromuscular disorders, that we really do use our history of what the patient's experiencing along with what we see at the bedside exam to then guide next steps, because there's a huge array of different diagnostic approaches that one can take nowadays. I would say that one of the things that's a bit unique about neuromuscular that we definitely use and is a tool that isn't as commonly available or something like it in other forms of neurology is something called electromyography and nerve conduction study, or EMG nerve conduction study testing, which is something that
this is what Kathy,
this is what I've had a couple times.
So the beauty of that, and again, it's a technology that's been around for a long time and progressively fine-tuned over the years, but it's this really beautiful way to kind of almost make that bedside examination that we do, where we're examining a patient, it makes that exam that much more sensitive. And then it allows us, if we see a patient on our examination, and we can detect weakness, it can tell us where that weakness might be coming from. Is that coming from the brain and spinal cord? Is it coming from the nerve roots? Is it coming from the peripheral nerves, the muscle? And so that test is oftentimes something that's oftentimes paired with our clinical assessment to help narrow down what we might be dealing with and guide treatment, and then to some degree can be used for tracking disease activity in some specific disorders.
I'm glad to know that within this specialty that patient-doctor relationship still exists. We hear so much about AI and it seems as though machines are going to take over. I'm glad to know that the doctor is still very much present with the patient and that dialogue makes a difference. It sounds like what you're saying.
Yeah, it really is integral to what we do. I mean, for neurologists, and we teach, this is something we'll teach to neurologists in training and medical students, is that a neurologist without a good history, will oftentimes, if the person can't provide the history themselves, we'll have to go to a collateral source. But a neurologist without a history is kind of, guiding they're basically walking like blind. They don't know where they're going with things, and they really anchor a lot of what they do to that history. It completely shapes what we do when we examine a patient, shapes what we think is going to be of help when we're pursuing diagnostic testing, and certainly is critical to making a diagnosis. So it's still very much in 2024 integral to the practice.
Ask you something. Is there something that we as patients can do to, in a preventative way, to I don't want you to take offense, but so we don't have to see you, doctor. We don't want to be your patient. Can I take a supplement? Can I change my diet? Can I exercise? Can I take vitamins? Do any of these things work?
Yeah, no, I think that it's a great question. I think, prevention is the best medicine. So it's a really, really great question. I would say that, again, getting back to kind of the breadth of neuromuscular disorders, depending if you're a lumper or a splitter, our field has literally thousands of diagnoses that fall underneath the umbrella of neuromuscular disease. And so depending on the specific disorder, there absolutely are certain things that can be extremely helpful. So if we take, one of the more common disorders that fall in neuromuscular disease, like peripheral neuropathy, one of the leading causes of peripheral neuropathy, particularly in the United States, are things like metabolic syndrome and diabetes. And there's really good evidence to say that, all the things that you hear about from your physician in terms of a good diet and exercise and all of these things, changing one's lifestyle, diet, all of these things, there's actually good objective evidence that you can actually modify, and actually patients with diabetic neuropathy can actually have objective improvement if they're able to get some of these factors under control, tighten up their blood sugar control, lose weight, deal with the other aspects of metabolic syndrome. All of these things have been shown to really make a huge impact on that particular disorder. And then, there's tons of other examples. There's patients that have certain forms of what we call metabolic myopathies, where by using certain supplements, they can prevent themselves from developing episodes of severe muscle weakness. And so, again, it gets back to, really we spend so much time up front with our assessment of patients to really make sure we have the diagnosis right, because it influences everything. And then, one thing I'll just mention about, since the questions about neuromuscular disorders, is we're still very much in our field in that position where there's a ton of things we don't know. And so there are a lot of patients where we don't have an answer. We might not know exactly what's going on. And we still are 2024 still in a position where another cornerstone of neurology and what we do is sometimes we're following patients, and with more time, we're able to get more clarity. As we get smarter, we're able to come up with better answers and achieve diagnoses for patients and provide them better care. But there's still a lot of things in our field that we don't know. We're still learning a lot day by day. So, but yeah, I can't give you a more specific answer to that question, just because it's each disorder is going to have a different answer.
Wow.
But taking good care of yourself is still the best medicine.
Absolutely. That's
the bottom line.
You always have to do what you have domain and control over. And I think there's a lot to be said for that, no doubt.
Now, in terms of managing these neuropathic conditions, do you recommend physical therapy or occupational therapy as part of the treatment plan, or are these therapies primarily aimed at minimizing issues or teaching individuals how to adapt to their new reality?
Yeah, no, I think that's another great question. And what I would say is, as a general kind of umbrella response, our field absolutely works hand in hand with physical therapy, occupational therapy, other therapy services. And it's integral to the kind of standard of care for so many of the disorders that we take care of. Our clinic has, and we partner with and have wonderful physical therapists that have always been part of our group at WashU and are present in our clinics and are great partners in providing care. I would say that depending on the disorder, there's varying levels of evidence. A general rule of thumb that will go off is, in terms of things like exercise, physical therapy, in general, there's very few, if any, disorders for which there's not going to be support for engaging these types of things. And the right, like any field, like we were talking about with specialization, there's certain physical therapists that are going to have a lot more familiarity with neuromuscular conditions and the specific therapeutic interventions that would be of benefit. Again, as I was alluding to, we have a great group here at WashU and a lot of great experience in historical kind of representation for physiotherapy within neuromuscular diseases here. And there's other great centers around the country. Without a doubt, some of that's going to tie into the fact that you're dealing with disorders that, unfortunately, the natural history or what you're expecting with those is progression, and you're expecting that patients will get worse with the disorders present day. And so some of that can be helping the patient navigate how they're going to live with that disorder and adapting to it and all of this. And then there's other disorders for which, we have good therapeutics, or there are therapeutics in development, or, we're on the verge of something kind of important moving through. And so for those specific disorders, there can be a very nice synergistic effect of physical therapy where timed out the right time, it can actually help hasten and improve the ultimate outcome and recovery. And so again, depending on the disorder you're dealing with, and the group you're working with, there's absolutely a role for it.
Wow. Now, are there some common symptoms or indicators that someone might be experiencing neuromuscular issues?
Yeah, so some common things, not specific to, again, every disorder, but oftentimes patients with neuromuscular disease will develop issues with weakness, problems with mobility. They can have problems with sensation, pain, balance, mobility. Depending on the disorder you're talking about, it can also involve things like speaking, swallowing, motility, breathing. Less common, but sometimes the case. And again, I was alluding to the fact that our specialty in neurology doesn't deal as much with brain and spinal cord disorders. So our field is going to end up dealing a lot less with like headaches or memory and thinking problems in general. Now, there's always exceptions to that, and some patients with certain forms of neuromuscular disease will be at risk of developing those types of things as well. But in general, those first things that I mentioned are going to be the more common types of symptoms that are going to lead a patient to end up to coming to see us. And sometimes, there are other areas of the nervous system, like the spinal cord, where people can, they see their internist, they're having sensory changes in their feet or problems walking, or their legs are weak, and they're like, oh, well, this must be neuropathy. And so they send them to see us. And it's when we do that examination that we can actually realize, well, this actually looks like it's probably more of a spinal cord issue. And then that might be a different neurologist. But for the most part, those initial symptoms I mentioned are going to be the kind of cornerstone common things that are going to lead somebody, whether it's the patient or a non-neurologist, to say this may be a neuromuscular issue.
Interesting.
So the adage is you should tell someone what you're feeling.
Yeah, absolutely. I think a neurologist is key. One of the cornerstones of what we do is really listening to what the patient's experiencing. And again, we teach this with with our trainees and students is really to get the best sense as to what, oftentimes, we're in clinic and we'll ask a patient, so, what brings you to see us, what's going on. And it's very common, particularly present day, people will oftentimes say, well, I went and saw this doctor and they told me I had this. And it's like, well, we don't want to know what, we don't want to know what you were told you have, but like, tell me what it is that, your day to day, your activities as you go through your day, what is it that's not right? And by hearing, well, I'm having problems, something as simple as one individual having a problem getting up and down off the toilet versus somebody else just having problems when they change surfaces as how they're walking. That could be a clue to a neurologist where a person's weakness might be or where you're going to think more about examining when you do your examination on that patient. So that's like, we want to know kind of what it is that you're experiencing, because that's going to help us kind of narrow down how we cater our evaluation and diagnostic evaluation.
Are there special risk factors that predispose someone to having these issues?
Yeah, so certainly a common one I alluded to. So metabolic syndrome, diabetes, definitely one of the more common causes of peripheral neuropathy, and certainly, an issue in the US and other developed countries. I would say that really it depends on which category you're talking about. There are, as we were alluding to earlier, a number of hereditary disorders or genetically determined disorders that are kind of at the forefront of neuromuscular medicine. And so a lot of those disorders are what we'll call dominant, meaning, if you have a family member, like a parent with this disorder, there's in general a 50-50 risk of you having an inherited risk to develop that disorder. And so there's genetic risk factors for certain disorders that are very common in neuromuscular. And then
I was just going to ask you that, doctor, about the role of genetics.
Yeah,
it's the role of a genetic counselor and genetic testing would play in your diagnostic journey.
Yeah, absolutely. And again, certainly here at our center, and I would say it's probably comparable to other centers. We're probably, and I don't have to say probably, we are the group at our center within neurology that does the most clinical genetics. We have a genetic counselor that now works with our group at WashU. And then for a lot of our clinical trials, we have genetic counselors that are part of the research team and the investigator team. And we absolutely, nowadays, it's very common, particularly with there being meaningful therapeutics available for folks with different forms of hereditary neuromuscular disease. Diagnosis, as I was alluding to earlier, is key. And so the earlier you have a diagnosis, the earlier you can get on meaningful therapeutics. And so because of that, for a number of reasons, there's a lot of widely available and easily accessible genetic testing. Genetic testing is something that, has gotten, just over the course of my time in medicine, is, the cost of it and its availability is just totally different than it was when I started training. It used to be, we had to do like everything to prove we wanted to do a one gene test by something called Sanger sequencing, which was long and laborious and very resource intensive. And nowadays, with the technology being what it is, the cost of what it used to be to do that one gene test is about the same as it is now to do like genome sequencing. And so that's a double-edged sword in that, there's a lot more data that you have to be able to navigate and deal with, because you're going to find a lot of things that, you might not have been able to do the genetic testing. And so that's where things like good genetic counselors, a deeper understanding of what the testing is that you're doing, its limitations, and then also like having partners. So we have really great collaborations and partnership with folks in clinical genetics here. So we know kind of what we know, but once we get outside the scope of things that fall outside our level of comfort or expertise, it is good to have additional experts available that can help us out.
Wow. Now, I've got to ask, for individuals who are already diagnosed with neuromuscular issues, what type of ongoing support or management strategies are typically available and are recommended?
Yeah, so I'd say that, again, depending on the disorders, you can use certain examples. So some of the really fantastic resources available for folks with different forms of neuromuscular disease, there's the Muscular Dystrophy Association, the ALS Association. These are great groups that provide a number of important, not only supportive measures, but a community for patients dealing with these disorders. I would say that, we've been able to, locally, we've been able to find that some patients more than others have actually wanted to provide that support for others going through what they've dealt with, particularly when we're dealing with like ultra rare diseases. I've taken care of patients that have said like, it was really tough to go through what I've gone through, given the lack of community with the fact that my disease is very rare and novel. And not surprisingly, with how selfless some patients are, they've said, I'm happy to, speak with anybody that might be dealing with this or that you do end up identifying. And a lot of kind of really amazing efforts have come of that, of kind of building one's own community. I would say that, between that and good patient physician relationship and, being taken care of at a center that, has familiarity with the disorder and what's out there, I'd say that there's been really amazing. I've had, over the last 10 years or so, been able to appreciate the value that patients get from the community kind of experience and the support that they get out of participating in clinical studies. I've had a number of patients that have participated in trials, and they've told us that one of their main reasons in the end that they continue to come to participate in studies is that kind of the community that they form in doing so by coming and participating, the nurses that they see every couple weeks or months, and the study team that they end up getting to know. It provides this additional kind of source of emotional, psychological support for some patients. So I'm sure there's probably others that I'm not thinking of, but those are some of the ones that are
So
commonly
beautiful.
utilized.
That's really interesting.
It's so nice. And,
That's really
it's
interesting.
exactly why we started this podcast,
Yes.
Was to build community and to make people feel anyone with rare diseases or medical challenge is almost everyone, that I'm not alone and neither are you. And it's so nice to hear what you say from the medical doctor perspective, just seeing the need that patients have, because we've seen so many patients that have been on the show really thrive by advocacy and by setting up foundations where there is a void, and just the type of activism and advocacy that you're talking about. And it's so wonderful to hear you just speak of it that way. Thank you.
And Kathy, we've also found that support groups, doctor, that you spoke about have also been extremely helpful for patients. So it's so interesting that as a provider, you are seeing this from your patients and the benefit.
I think absolutely. I think medicine is so rushed now, and like even we're very privileged being in an academic center where we get like a whole hour budgeted to spend with a new patient. Like it's still not enough time, right? Like to really get to know how a disorder impacts a patient and all that goes into it beyond just like the very brief snippet you get when they come to see you every few months or once a year. There's so much more to a disorder than that. And so I think there's so much value that can be offered sometimes. And this is definitely the case. The folks in our clinic, like, again, I think one of the reasons patients oftentimes benefit for participating in clinical studies and trials is, of course, we hope that the trial and the therapeutic intervention being tested will benefit them, but they have a lot more contact, a lot more time with the study team. There's a lot more, you're not limited by that 30, 60-minute clinic visit.
Right.
So a lot more that can happen during that time to really understand what's going on. Maybe a longer conversation is what really leads somebody to understand a little better what somebody's dealing with. So I think that these formats and these venues oftentimes can be, depending on the disorder you're talking about, of more value to just going and seeing the doctor every 3-6 months, whatever it might be. So much of what we do in neuromuscular is multidisciplinary. And I stand by the fact that, if we take ALS as an example, the physical therapists and the speech therapists and the respiratory folks and our social worker and our dietitian, they do so much more for those patients than I do. And it's just so, so important. And oftentimes it's resources and time that are the greatest limiting factor.
Wonderful. Well, I've got to ask you one other question. And how do neuromuscular neurological issues impact daily life and functioning from what you see? And what strategies can individuals use to cope with all these challenges?
Yeah, so I think depending on the disorder, it's going to vary quite a bit. For disorders that affect motor function and affect strength, it can be very, very debilitating and lead to the need for a lot of modifications to one's home. People sometimes have to move to a single level home. They have to completely redo their bathroom, redo their bedroom. They might need beds that allow them to get up and out of bed. They might need Hoyer lifts. Oftentimes what we're doing is partnering with occupational therapists that can go into patients' homes and really look at how they live their life, like how are they getting through their days, what they need to do, and then they can make recommendations. And again, this is another area that can be very resource intensive, and we try and do what we can. And
is it generally evolving so that if someone comes in and were to make that assessment, it would change?
Yeah, it can. And so, again, that's the idea of working with folks that have some familiarity with what the trajectory, natural history of these things might be, so that, they don't have somebody completely overhaul like their home to do something, and then 5 years later, it's a moving target and required.
Right.
It could be something as straightforward as for folks that have loss of sensation in their lower limbs, something as simple as a grab bar in the shower could be a huge impact and help them from having a very high risk fall in a dangerous environment like the shower.
Wow.
So I call them small things. They're actually very big things, but things like that are sometimes things we can pick up in clinic, but again, it's oftentimes quite helpful to be able to partner with folks that can really see patients in their home living environment and make recommendations to us to make sure that they can, again, live their life as independent as possible and acknowledge that, as you were alluding to, that things change and it's a bit of a moving target.
Dr. Bucelli, you alluded to clinical trials. Tell us about some developments that you find personally exciting. What's on the horizon?
So the thing that's been really exciting in recent years here, so our center, if I talk about ALS, so within the world of ALS, we've been involved in a number of different programs across the whole spectrum of the field of ALS. One area in particular that we've been very involved in is with the use of antisense oligonucleotides, and one of the reasons for that is the co-director, and really I'm a co-director of the ALS Center, but the real director of the ALS Center at WashU, I would say, is Tim Miller. He's somebody he's a physician scientist, a brilliant guy that's devoted his career towards this aspect of medicine, this really amazing biology that allows us to kind of knock down the products of genes via antisense oligonucleotide therapy. And so he's been working in the ALS world for a long time, and one of the drugs that he helped develop in his lab eventually made it through development and was just FDA approved.
Oh, that's great.
A year and a half ago, and that, I think, if I'm not messing that up, I think it's a year and a half ago now. Time flies, but the bottom line is this drug has really changed the way that a number of us have thought about that particular disorder. And it's probably just the first of a number of drugs in that category of drugs that will really make a big impact on that disorder, for which, is long overdue for some big wins. And so,
how do socioeconomic factors or access to healthcare services generally affect the diagnosis and the treatment of neuromuscular neuropathic conditions?
Yeah, I would say that it's a really important question. I would say it's not unique to our field. I'd say that as we were talking about, access to neurologists, including neuromuscular doctors, has been shown through good evidence that certain socioeconomic factors, location, all of these things will definitely lead towards certain populations not having access to the resources, whether it be neuromuscular or other forms of neurology. And that includes, one of our former trainees did a nice study showing that even access and pursuit of genetic testing through the population locally within neurologic disease was very different based off socioeconomic status and other variables. And I think that it's not unique to our field. I'd say our field follows suit with others that have shown that certain groups are definitely being missed and not having the same access to care that others are. And so I think, there's definitely been more awareness of this and a concerted effort towards strategies to address that gap, but it's no doubt nowhere near where it needs to be.
Where it needs to be. Now, are there any emerging technologies or innovative approaches that really hold promise for improving the management of neuromuscular neurology issues?
Yeah, so in terms of, those we were talking about genetic disorders or hereditary disorders, I think, the therapies like based therapies, which is not quite antisense, but targets the same kind of part of the pathways.
Right.
When you talk about a gene product moving down to its protein. ASOs have been encouraging more and more, and this is now just recently with this technology being used to help patients with sickle cell, things like actual gene editing. And
that's what I need.
There's all these challenges associated with that, but with the breakthroughs that have happened with sickle cell, you have to imagine that it's not far off before those technologies will actually be able to be applied to our field in neurology. We have had, particularly in the pediatric neuromuscular world, some just incredible breakthroughs and home runs with using vector-based true gene therapy, where genes that, a lot of what we've talked about so far are knocking down toxic products. A lot of disorders are due to the absence of a needed protein. And so these vector-based genetic therapies, like an example being the therapy that was approved a few years ago for spinal muscular atrophy, which is a pediatric onset motor neuron disease in the neuromuscular world, that intervention has just completely changed the face of that disorder. And so again, that's not the only disorder for which gene therapy is truly available now, but more and more, looking towards using these types of therapies for things like muscular dystrophy and other neuromuscular disorders is certainly on the horizon.
Very exciting.
Yeah. So, Doctor, closing, what parting advice would you give to patients and to our listeners?
Well, again, this might sound like a little bit of a pitch towards getting people to go into neurology and pursue neuromuscular medicine. But what I would say, and I think it applies to patients in the community too, is the pace and rate at which things are developing and evolving and changing is just staggering. And our field is rapidly changing. Things that I think a number of us in our field never thought we'd see in our career is now happening with, again, as I was alluding to, the breakthroughs that have happened in ALS therapeutics and really redefining what's possible. I'd say that that's just one example of many where it's this really beautiful kind of marriage of enhanced knowledge, but also enhanced technology and therapeutics that really makes the next few decades of what we do really encouraging to consider.
I wish you very good luck in improving the lives of so many people who need your help, Doctor.
Absolutely. And Dr. Bucelli, you are just doing amazing, meaningful, wonderful work. And I thank you. And I thank you personally. You are one of my heroes and really have helped me in my journey. And thank you for being a guest on It Happened to Me today. You really have helped share your wonderful insight and wonderful information on neuromuscular neurology, and we've learned so much from you. Thank you for being here today. It happened to me. I'm not alone, and neither are you.
Very much appreciate it, and I'm flattered by the words. I don't know if I deserve them, but I'm very, very much appreciative, and thanks for the opportunity to chat.
Oh, we're thrilled to have you. Thank you.
Thank you for listening to this episode of It Happened to Me. We encourage you to learn more at ithappenedtomepod.com. Please use the contact form on our website to submit your guest suggestions, comments, questions, ideas, and feedback for the show. You can also email us directly at ithappenedtomepod@gmail.com. We would really appreciate it if you can leave us a 5-star rating and review on your podcast app like Apple or Spotify. This helps others in the rare disease and medical challenge community find us. It Happened to Me is created and hosted by Kathy Gillenhorn and Beth Glassman. I'm Keir Deneen from DNA Today, and I serve as our executive producer and marketing lead. Amanda Andrioli is our associate producer. Ashlyn Anokian is our graphic designer. And remember, it happened to me. I'm not alone, and neither are you.